Thank you, Professor Kim, for the introduction and for this very gracious invitation to speak to this group. It's a real honor. I also wanted to thank Dr. Logan Koo, whose father is here today, but I can't see where he is. Dr. Koo provided the Korean language translation of my slides, and I hope you can see them. So this morning you've heard some talks about the knee and general health related to patients who have knee problems. This talk is going to be a little bit different. This is a little bit more about where this knowledge comes from and how surgeons can use it and use that knowledge more effectively. So this is the full title, but since Professor Kim explained to you I'm an editor, we needed to edit this title down to something more practical. So that the talk is really about orthopedic knowledge and the surgeon and how it affects the patients. So again, it's a real honor to be here visiting with you today. I have a financial disclosure to make, and that's that my work is supported through my job as an editor, and they pay my salary to my university. So this talk is going to be in two parts. The first one is what doctors and surgeons and knee surgeons ought to do when we don't know the right answer to a problem. And the second half is what we should do when we do know what the right answer is to a problem. And the first one, although it seems like it ought to be difficult, I don't think is. But the second one, although it seems obvious, can be very tricky. So let's begin with what we ought to do when we're unsure. And if we're being honest with ourselves, this is most of the time, because most of the research that surgeons use is retrospective, comes from retrospective studies. And retrospective studies have a lot of problems with different kinds of bias, including selection bias, that the groups are different before treatment, and those between group differences can affect the outcomes that we care about. Transfer bias, which really is another word for loss to follow-up or incomplete follow-up, and the missing patients aren't usually doing as well as those who are accounted for. And assessment bias, which is that the surgeons who are doing the studies generally did the operations, and then they're generally grading their own work. And as you know, that when we get to grade our own work, we're usually very forgiving with ourselves. Those biases don't offset one another. They add together to have this effect. These kinds of bias inflate the apparent benefits of the treatments that we're studying. In other words, they make us look better than we really are. And that's a problem. Let me give you an extreme example that I remember from my own residency. A faculty member said that he invented a new operation, and he did it 7 times. And none of the patients came back for follow-up. And so this professor assumed that all of his patients must have been doing okay. And I think the surgeons and physicians in the room know that this really isn't how it works, because the missing patients usually are not doing as well as the accounted for. This really isn't correct. More practically, we'll look at a typical example. This is knee arthroscopy for a degenerative meniscus tear, which I think is another example where surgeons trick themselves into thinking they're more effective than they really are, because they usually only follow those patients long enough to make sure the postoperative pain is gone, a month or 2. And really, that's as good as the patient is going to look. The patient has been pretty miserable with pain for the first few weeks. The postoperative pain's gone, the patient's happy. The surgeon thinks the patient's going to stay happy. But what happens after that? A few months to get back to what is supposed to be normal, but it never really happens. Then a few months to try to find a joint replacement surgeon because the operation didn't work in the first place. Then a few more months on the wait list for that surgeon. A few months to schedule surgery. By then, it's a couple of years out. The surgeon who did the arthroscopy a year or 2 ago has no idea how this patient is doing. All that surgeon knows is that 3 or 4 weeks after the operation, the patient was happy. And that's not really reflective of how these patients are doing. And so that's why the randomized trials are so much more important. So making things worse even is that a lot of the conditions we treat aren't as common as that. And so we can't always get rigorous studies like randomized trials. And so case series, which is most of orthopedic research once again, are very susceptible to the placebo effect. And for those of you who read orthopedic journals, maybe you can find this interview with somebody whose whole career has been spent studying placebo effects. His name is Ted Kapchuk, and it was a fascinating interview. The surgical placebo effect is about 50%. In other words, if you were to do an operation that didn't do anything except have a placebo effect, bring a patient into an operating room, make an incision on the knee and wake the patient up with a Band-Aid or bandage on the knee, 50% of those patients would say that they're feeling better afterwards because of the commitment to the idea of surgical treatment. Pharmacologic placebos are about 35%. Worse still is something called the Kruger-Dunning effect, which is the idea that we all overestimate our abilities. We all believe we're better than average drivers or better than average kissers, and we can't all be better than average. Another example of the Kruger-Dunning from the vaccine wars is that the less somebody knows about vaccine science, the more certain that person is that his or her view is correct. Surgeons, being people, almost certainly overestimate the quality and the strength of evidence in support of the treatments that they like to use, the effectiveness of those treatments, and perhaps most importantly, their own abilities. And so all of that is a lot of bad news, and here's more bad news. I'm a journal editor. I can't fix this. This is part of human nature. You can't fix this either. And so what are our options? Well, we can throw in the towel and give up, or we can think about what are our best professional values and use them to deal with this kind of uncertainty. And I think I'm going to make a list here of our best professional values. I think they're integrity and intellect, modesty and caring or empathy. By empathy, I want to remind everybody here that although what we do in the office every day is common to us, it's not common to patients. It's a new experience to the patient. And so the symptoms, the diagnoses, the imaging tests, the uncertainty, all causes emotional distress. And our profession tends to generate emotional distress much more effectively than it tends to relieve emotional distress. It takes time and care to address uncertainty and emotional distress, and not every surgeon spends that time and that care with his or her patients. But when we don't, we have a tendency to worsen health rather than to improve it. And it makes it harder for patients to make decisions that are consistent with their own personal values. So breaking this down a little bit, by integrity, what I mean is when we're unsure about the right decision, we have to tell the patients that we're unsure and work through that uncertainty in partnership with them. We also have to tell them that some of the treatments that we apply, in fact, most of them, have the potential to cause harm as well as to help people. Intellect, here, this is a little bit technical, and I apologize to the patients in the room. We're talking about effect sizes and minimum clinically important differences rather than just focusing on p-values. So if you're a knee surgeon, you should know for each outcomes tool that you use what the minimum clinically important difference is. Is it 5 points? Is it 10 points? Is it 20 points? So that you can decide whether a study is just showing you a p-value, a statistical difference, or a clinically important one. We need to get over our affection for p-values. And we have to look instead at endpoints that patients care about. We heard a little bit this morning about navigation and robots. Is a patient likely to notice a difference of a degree or two in the alignment of a component, or does a patient really care more about pain and function and durability of the implant? And I think it's the second one. The professional value of modesty is we have to admit that the placebo effect, as I mentioned before, is a big part of our result, especially when the evidence quality is low, as it so often is. And that needs to inform our decision making. And it should cause us to lean away from surgery, not towards it. How about empathy or caring? So I would challenge the surgeons in the room, instead of looking at patients who've come to you who have taken a pill and taken a shot for their knee pain, and you say, well, the patient has failed non-surgical treatment because they've tried a pill and a shot, that doesn't necessarily mean that you have to offer surgery. Sometimes you can help the patient to adapt to his or her symptoms, even though you've tried reasonable non-surgical treatments. Perhaps the surgery isn't going to get the patient what he or she wants, and even though the patient has tried other things, maybe adapting to the condition still is the right thing to do. You can't just say it, though. You have to help them to adapt. What would that look like? And that's different for each patient. For some patients, it's substituting a different exercise routine. For others, it's making peace with one's own body and how bodies change as we age. So now let's change gears to the back half of the talk, changing from what to do when we don't know what to do to what we should do when we actually do know, when the research is strong. And what's interesting here is that we don't always apply what we know. And I want to talk a little bit about why that might be and the harms that it causes. So here we're talking mainly about the problem of overdiagnosis and overtreatment. And so I would say that we have an epidemic of overdiagnosis. We're using too many diagnostic tools too often, and that results in an epidemic of too much treatment. What you need to know is that unnecessary or ineffective operations are by definition harmful, even if they don't cause a complication in a specific patient. We can talk about why. This also pushes us towards some missed opportunities to help patients to improve their health in broad and meaningful ways. We need to realize and remember that even though a lot of people in this room are knee doctors, we're not just bone doctors, we're physicians. We take care of patients, we don't take care of knees. And this problem in our thinking has caused us to focus excessively on what I would call a biomedical model, looking for a nameable cause as opposed to working with the patient to cope with his or her own body and things that might change in the context of the patient's emotional health. So how about overdiagnosis? Let's talk a little about shoulder pain. Almost 5 million visits to doctors every year, most of them presenting with the typical pain with overhead movement, generates lots and lots of MRIs and diagnoses like impingement and subacromial pain or bursitis, cuff or biceps tendinopathy, very nonspecific diagnoses. In the spine, you get an X-ray, the X-ray leads to an MRI, the MRI has a finding on it that may or may not be important or meaningful. What we need to realize is that joint pain, spine pain is part of aging and part of life, and so not everything that we see on an imaging test deserves a treatment. But when these age-related normal changes, like some pain sometimes or these findings on MRIs, overlap with common age-related clinical findings like pain, you tend to wind up with overdiagnosis. We put a name on it, and as soon as we've named it, we want to try to cure it, often with an operation. What are the harms of this? Lots of unnecessary invasive tests, potentially lethal procedures, lots of costs, arthroscopic surgery for degenerative changes in the adult knee, which has been disproven as a therapy, costs over $3 billion a year in my country. Causes a lot of emotional distress. Here's a fact that I didn't know until I researched for this talk. The incidence of myocardial infarction doubles in the year after prostate cancer diagnosis in older men. Now that prostate cancer diagnosis almost never will kill an older man, very rarely, but the myocardial infarction from the stress can. So this is a very common problem. If you look at the low back pain, we say, well, we don't order MRIs unless there's a red flag indicating an MRI, but the problem is that the red flags as defined by doctors are present in 8 out of 10 patients. The idea that pain was a fifth vital sign led to an opioid use crisis, of which you're all aware, that has been so severe that it's reduced the life expectancy in my country. The idea that more or newer is better has resulted in a large number of unhelpful and unnecessary treatments like stem cells, new implants, robotic tools that have never been proven to help anybody do anything better. So I'm going to leave aside for the purposes of this talk. I'm not going to cover the many topics for which there is little evidence. I'm going to focus on only a few for which there is a lot of evidence. I'm going to limit the remainder of this talk to things that we've done randomized trials, including placebo-controlled surgical trials. So this is very strong evidence. And there is evidence against using the arthroscope in an adult knee for almost any meniscal finding in middle adulthood or later. There's randomized trial evidence against using an arthroscope to treat impingement in the adult shoulder, acromioplasty for rotator cuff repair, and many or most slap tears. There's randomized trial evidence against spinal fusions for low back pain or degenerative changes in the adult spine. These are 3 of the 10 most common operations that orthopedic surgeons perform, and all of them have been disproven in randomized trials. What's interesting is if you ask a spine surgeon, should a knee surgeon use an arthroscope like this, the spine surgeon would say no. If you ask a knee surgeon, should the spine surgeon be doing these fusions, the knee surgeon would say no, but the spine surgeons keep doing these spine operations and the knee surgeons keep doing these knee operations. So more on overtreatment. The diagnoses have changed over time. It used to be arthritis of the knee, then it was chondral or cartilage changes, then it was degenerative meniscus tears, but the treatments remain the same, knee arthroscopy. The names of the diagnoses in the shoulder have changed over the last 20 years. from impingement to subacromial pain to bursitis, all of these new diagnoses, but the treatment hasn't changed. And so the question is, if we keep changing the diagnosis, why can't we give up this operation that we've proven doesn't work? So here's a practice guideline from the British Medical Journal based on a large amount of randomized trial evidence regarding shoulder scopes for subacromial pain. The panel concluded that any informed patient would decline surgery because there's no benefit, but there are harms. And so subacromial decompression surgery should not be offered in this context. However, this is one of the 10 most common operations in the United States that orthopedic surgeons perform. The evidence is even stronger in the adult knee. This is from last year, where we pointed out why the new American Academy guidelines on knee arthroscopy are a step in the wrong direction, because they continue to recommend it. And they based it on 3 studies, but there are more than a dozen available, all showing the opposite. Again, the biggest problem is that the new guidelines are at odds with the best evidence. They misuse the small amount of evidence that they quoted. And the concept of offering surgery to these patients who have failed physical therapy, we talked about that before, is a failed idea and shouldn't be used as a basis to recommend surgery. So why is this happening? We can think about this as a problem of incentives. Many surgeons get paid more the more operations they do, but I tend to conclude this too quickly, and I don't think that's necessarily fair to surgeons. It could be part of the story, but it's not the whole story, because in places where they don't get paid more, like Spain, the same problem exists. It's really more a problem of cognitive biases and logical fallacies. I'll see it when I believe it. In other words, you have to change what's in your heart before you can change what's in your head. The placebo effect, assessment bias, grading our own work, loss to follow-up, as we've talked about before. And so I'm going to stop for a quick moment to say that I'm not blaming surgeons for doing wrong here, and I'm no better than anybody else who's making this mistake. I'll give you an example from my own practice. When I started, I used to do about 1/3 of my total knee replacements as same-day bilaterals, which I think now the best evidence suggests is risky. And I thought it was efficient. I thought my patients loved it, but you could say everybody loved it except the ones who died unnecessarily. And it was difficult to see that increased risk of death in the context of my own practice, even though it was a large one. We needed large registry studies. When those registry studies came out, I had trouble believing them because they seemed to be different than my experience. But that doesn't make the findings any less real or important. I found quitting what I was doing very difficult to do. I was well-intentioned. I thought I was helping. It took me a while to realize that I was hurting people, not helping them, because my intentions were good. And I think that's true for a lot of surgeons. So these biases that we talked about, they tend to be additive. They tend to make us feel more effective than we really are. So how did we get here? This is the concept of the biomedical model. We're looking for a nameable diagnosis. And for a long part of medical history, most of the 20th century, this was a good model as we were developing diagnostic tools and learning more about the body in the modern age of medicine. But it's no longer the best model. I think a biopsychosocial model is a better way to think about it. And just as helping somebody to quit smoking has benefits that go beyond the lungs, if you were in the knee clinic, but you notice somebody with emotional distress who's got anxiety or depression, helping that patient cope with that emotional distress will help the emotional distress, but it will also help the knee pain. And what's nice is it works both ways. You know, the more the knee pain gets better, the less the emotional distress, and vice versa. So I'm going to wrap up by giving the doctors in the room the chance to see some things that they never wrote when they applied to medical school. Nobody in this room ever said, I want to do more carpal tunnel surgery than anybody else in Seoul, or I want to do as many joint replacements as Professor Kim. Nobody has ever written that on an application essay. What did we say? What we said was, we didn't say this either, by the way. We didn't say we want to make lots of good-looking x-rays. What we did say is we want to help improve health. We want to help patients to feel better. We want to connect emotionally with our patients and walk alongside them as they heal. And even sometimes as they don't heal, we want to help them. We want to be there for those patients who aren't going to get cured by supporting them, even if times are difficult. We want to integrate science into our practices. These are the things that we said we were about, and it's good to focus on them again and come back to them even in mid or late career. So what can you do? What can we do? If you see your partners who are doing these operations that shouldn't be done, you can ask them, Well, there's been a dozen randomized trials showing that this knee operation is not effective. What kind of study would it take if it wasn't those dozen trials? Can you conceive of a study that would convince you? Because if you can't conceive of a study that would change your mind, then we're no longer practicing science, we're practicing religion. We have a belief that we can't leave behind. Our ideas must be scientific. We have to be willing for them to be falsifiable, that is, that a study can disprove them. Our beliefs should be hypotheses that we test, not treasures that we guard. What else can you do? You can learn how to read journals effectively. We've got some tools at clinorthop.org that can teach you how to read better, that can help you practice in the context of an article that you're reading, and they're free for anybody to use. And you can practice those skills. You can volunteer to review for your favorite journals. If you see an article in your favorite journal that doesn't look correct, write a letter to the editor saying it doesn't look correct. In the 11 years that I've been an editor, I have published 100% of the letters to editor that I receive because that kind of dialogue is so important. What else can you do? If you're a researcher, you can publish thoughtfully. Don't use preprint servers to disseminate your research. That helps the researcher, but it doesn't help the patient. Don't publish in low-quality journals. Publish in high-quality journals. If a journal doesn't justify your time as a reader, don't support it with your research. If your paper's been rejected a few times, think about whether trying to find some place to publish that paper is going to help people or not. No doubt you can publish it somewhere, but what is the benefit of publishing something that isn't perfect? Thank you for your time and attention.
Thank you, Seth.